Hey everybody, we've got another heart today. This is specimen 879 in our collection, and the heart would have sat in the chest like this, anterior coming out towards the screen, posterior towards the turntable, superior ahead up here, inferior legs down here, left over here, right over here, and right off the bat you can see that there's something just odd about how this heart lies, and why don't we go figure out why. Externally we find a very large broad-based pyramidal triangular appendage, which is consistent morphologically with a right atrial appendage, at least externally. So why don't we open up the heart from there and work our way around. So when we open up this atrium, we see pectinate muscles that spill outside the confines of the appendage, consistent with the morphologic right atrium. We do find a large atrial septal defect in the oval fossa. We see the mouth of the coronary sinus, which is back here. Thus, we find that the mouth of the coronary sinus, the tendon of Todaro here, and the right atrioventricular groove form the triangle of Koch. And it is at the apex of this triangle that we expect the atrioventricular node to sit, so that would be right here. And so once again, at the apex of the triangle of Koch, which is bounded by the coronary sinus, the tendon of Todaro, and the right atrioventricular groove, really truly the hinge point of the tricuspid valve, at that apex is where you find the atrioventricular node. The issue with the triangle of Koch right now is that, in fact, this tricuspid valve is not normal, and the tricuspid valve hinge point is, in fact, displaced and not at the level of the right atrioventricular groove, which would be right around here. So this is where we would expect the tricuspid valve hinge point would be, because the right and left atrioventricular grooves mark the levels of the right and left atrioventricular valves, aka the tricuspid and the mitral valve. So what we do find here is that the tricuspid valve is abnormally rotated or abnormally positioned. And we can see that we are dealing with a heart that has Ebstein's malformation. Now, it's important to note that the heart would sit like this in the chest. That would be the attitudinally appropriate position of the heart. And so you can see that if the tricuspid valve's hinge point would normally be here, for it to be inferior displaced, it would have to leave the heart, which would be nonsensical. And so, in fact, what happens in the setting of Ebstein's malformation is that the tricuspid valve and its hinge point is truly just abnormally rotated, right? Inferior displacement of the tricuspid valve, which is usually kind of what is stated and described, would mean that the tricuspid valve would have to leave the heart. And so, when we look at the heart in attitudinally appropriate position and not the Valentine orientation, then we find that inferior displacement is actually not an accurate term to use. Nonetheless, let's go ahead and find the septal leaflet, which is right here. You can see it's not very well delaminated from the underlying myocardium. The valve leaflet itself seems very thickened and rolled at the edges here. If we look at the inferior leaflet of the tricuspid valve here, you can see that it's hardly delaminated from the underlying ventricular myocardium, and its edges can be found here, which are also kind of thickened and rolled. All right? So a very large inferior leaflet that's truly not excavated from the underlying myocardium here, and you can see that well here. And then here is the anterior leaflet, which is also quite large, and what is sometimes described as sail-like here, right? And the whole kind of tricuspid valve apparatus and hinge point is actually quite rotated and displaced from normal. That leads to the so-called atrialization that occurs on the right side, so from the right atrioventricular groove level to the level of where the ends of the tricuspid valve leaflet are here. This portion is all quote-unquote atrialized. We do find the right ventricular cavity here, We find the distal edges of the tricuspid valve here. And this ventricle does appear to have coarse trabeculations consistent with the morphologic right ventricle. There does appear to be a septomarginal trabeculation here, also consistent with a morphologic right ventricle. And once again, we can see this large sail-like anterior leaflet. And then here is the septal leaflet, which is quite diminutive here. As we come up the right ventricular outflow tract, we find a semilunar valve. It has 3 leaflets. There's a third. It has 3 sinuses. There are no coronary arteries arising from any of the sinuses. It does appear to be a pulmonary valve. And just to note, as always, that the semilunar valves are hinged in a way that there are, between the fibrous valve leaflets, there are in fact triangles of myocardial tissue. Thus, the true annulus of the pulmonary valve and the aortic valve actually make this crown shape. The circular or oval structure that we term the annulus is actually a man-made construct, and I'm not saying it's not a helpful structure, but in fact is not the true annulus, which is in fact crown-shaped. Here's the pulmonary trunk, and the branch pulmonary arteries have been transected. If we flip the heart over to the back, we find another atrium. This one is smooth-walled. Here's the opening to its appendage, and we can find that there are pectinate muscles which are confined within the appendage itself, consistent with the morphologic left atrium. Here we see the defect in the oval fossa again. And we see that the left atrioventricular junction is guarded by a 2-leaflet atrioventricular valve. This valve has no connections to the ventricular septum, so a morphologic mitral valve. The ventricle that it's connected to does have fine crisscross trabeculations consistent with the morphologic left ventricle. As we make our way out of this ventricle, we find a 3-leaflet semilunar valve with 3 sinuses, and we do find coronary arteries arising from within these sinuses, consistent with an aortic valve. We also find that there is fibrous continuity between some of the leaflets of the aortic valve and the anterior leaflet of the mitral valve. And so unlike the pulmonary valve, the aortic valve is not entirely supported by muscle, but actually has some fibrous and some muscular support. But similar to the pulmonary valve, the aortic valve also is semilunar in nature, and its true annulus is also kind of this crown shape and not truly circular or oval, because once again, the fibrous valvar leaflets have muscular triangles. So myocardial triangles inside, and obviously this triangle here, this interleaflet triangle, is fibrous in nature because of the mitro-aorto continuity. Here is the ascending aorta, transverse arch, and then the head and neck vessels here. So to go back to kind of the highlight of this heart, an abnormal tricuspid valve with abnormal rotation, not inferior displacement, consistent with Ebstein's malformation.